Imagine you've just, survived a devastating house fire. You made it out.
Right.
The flames are extinguished, and literally everyone is telling you how lucky you are. But when you step back inside to, rebuild your life, you realize the high-pressure hoses used by the fire department to save your home have caused a massive catastrophic flood.
Oh, wow. Yeah.
The structure's standing, sure, but your daily reality is wading knee-deep in murky water. The drywall is rotting, and the damage is just life-altering. You survive the fire, but living in this flood feels completely impossible.
That paints an incredibly vivid and, frankly, heartbreaking picture.
Yeah.
And sadly, it is the exact medical and emotional reality for countless women who survive gynecological cancers.
Mm-hmm.
I mean, the oncological treatments save their lives, they put out the fire, as you said, but the physiological aftermath of those treatments can leave a survivor feeling entirely abandoned in the wreckage.
Exactly. And that tension right there is our mission for this deep dive. We are talking directly to you, the listener, especially if you or someone you love is navigating life after cervical or ovarian cancer.
It's such a crucial topic.
It really is. So we are looking at a stack of highly specific, very recent medical literature today to get some definitive answers. We've got the 2024 consensus guidelines from the British Gynecological Cancer Society, also known as the BGCS,
Right.
and the British Menopause Society. Plus, we're looking at the NICE NG23 guidelines and this major retrospective study out of the Cleveland Clinic.
That's a really solid stack of sources.
Yeah, we brought the heavy hitters. Because our goal today is to answer one critical and often terrifying question for you. Can localized topical estrogen ever be safely considered for a cervical or ovarian cancer survivor? And what do the latest consensus guidelines actually dictate?
It is a question that carries just so much psychological weight.
Oh, I can only imagine.
If you've survived a gynecological malignancy, the very concept of introducing any form of estrogen back into your body, it can feel like throwing gasoline on that fire you just barely survived.
Okay, let's unpack this because the toll of these life-saving treatments is severe. We're talking about things like pelvic radiotherapy, harsh chemotherapy regimens, or the surgical removal of the ovaries.
Well, bilateral oophorectomies, yeah.
Right, those. They don't just eradicate the cancer cells. They often plunge a survivor overnight into a sudden, severe surgical menopause.
Which is incredibly jarring for the body.
Exactly. And we aren't just talking about a few hot flashes or some mood swings. We are talking about GSM, or genitourinary syndrome of menopause.
Which is a highly clinical, somewhat sterile term for an incredibly agonizing condition.
It really sounds like a bad mobile phone network, honestly.
It does.
But the reality is severe vaginal dryness, structural changes to the tissue, and excruciating physical pain that disrupts every single aspect of a person's quality of life.
Yeah, it's devastating.
But if you are dealing with GSM, you are likely terrified to use any hormone to treat it. The underlying fear is always that the hormone might, feed a microscopic dormant cancer cell.
Right.
So this deep dive is entirely designed to separate that very valid fear from what the latest clinical facts actually tell us about safety.
And to do that effectively, we have to look closely at the tools on the table, because the phrase estrogen therapy triggers a very specific image for most people.
Like a pill or something.
Exactly. They usually picture a pill, a large patch, or maybe a gel pump. That is systemic hormone replacement therapy, or HRT.
Right.
But the guidelines we're looking at today draw a massive, thick, uncrossable line between systemic HRT and localized topical estrogen.
And the distinction between systemic and local isn't just about, where you put the medication. It's about the sheer scale of the dosage, right?
Precisely.
Because the systemic HRT you mentioned is designed to flood the bloodstream to treat body-wide symptoms like osteoporosis or brain fog.
Yeah, it's systemic. It goes everywhere.
But localized topical estrogen is a completely different ballgame. It comes in the form of ultra-low-dose creams, passeries, or these tiny vaginal tablets.
What's fascinating here is the paradigm-shifting math laid out in those 2024 BGCS and BMS guidelines. The sheer difference in volume is staggering.
Give us the breakdown.
Well, with current low-dose topical vaginal estrogen preparations, the total administered dose for an entire calendar year is equivalent to just a single dose of systemic oral therapy.
Wait, a whole year?
A whole year.
So you could use a topical vaginal estrogen cream every prescribed day for 365 days, and your body has only processed the equivalent of popping one single systemic HRT pill.
One single dose.
Yes.
That is wild.
It is, and it works because it is applied directly to the site of the problem. The estrogen is absorbed into the vaginal mucosa to heal that specific localized tissue.
Osteoporosis.
It plumps the cells, restores the natural elasticity, and increases local blood flow with absolutely minimal absorption into the wider bloodstream.
See, I was trying to visualize how this minimal absorption actually plays out in a real human body. Because my initial skeptical thought is that any hormone placed in the body is going to circulate eventually, right?
That's a fair assumption.
But then I started picturing atrophied vaginal tissue, like a bone-dry, cracked kitchen sponge.
That is actually a brilliant mechanical comparison.
Really?
Yeah, because when the vaginal tissue is atrophied from a severe lack of estrogen, it becomes incredibly brittle.
Right.
It loses its collagen, it thins out, and is full of micro tears.
Okay, so if you pour a little water on a completely dried out, cracked sponge, the water doesn't stay on the surface. It leaks right through the cracks onto the kitchen counter.
Exactly.
And the counter, in this analogy, is the bloodstream. So initially, some of that topical estrogen is getting into the system, right?
It is. When a woman first starts using topical estrogen, because the tissue is so thin and compromised, there actually is a tiny temporary spike in serum or blood estrogen levels.
So a little bit of water hits the counter.
Yep. Exactly. A little bit hits the counter. But as the estrogen does its job over those first few weeks, the vaginal lining thickens. It heals.
Oh.
The cells plump up, and the tissue essentially acts as a revitalized, healthy barrier.
The sponge gets healthy and starts retaining the water locally.
You've got it. Established use of topical estrogen normalizes serum estrogen right back to standard postmenopausal levels. The leaking stops.
That makes so much sense.
And because of this specific biological mechanism, the overarching consensus standard from the 2024 BGCS and BMS guidelines is incredibly clear.
Which is?
Vaginal estrogens are safe for the vast majority of women after treatment for a gynecological malignancy. And that explicitly includes women from whom systemic HRT is strictly forbidden.
Wow. Okay, it makes total sense that local estrogen would be safe if it stays local. But let's take this biological foundation and look at how the guidelines apply it to a specific disease, starting with cervical cancer.
Let's do it.
Because the science here seems overwhelmingly supportive of using estrogen, yet there is still so much hesitation and stigma among patients and, honestly, even some doctors.
Yeah, it's unfortunate. The hesitation usually stems from a fundamental misunderstanding of the cancer's biology.
How so?
Cervical and vaginal cancers are fundamentally not hormone dependent,
Oh, interesting.
right? Unlike certain breast or endometrial cancers, estrogen simply does not drive the growth of a squamous cell carcinoma of the cervix. So the guidelines state definitively that HRT, both systemic and therefore local, is not contraindicated.
I was digging through the sources, and the data backing this up isn't even slightly new. Like the PLOC study caught my eye immediately.
Ah, the 1987 trial, yes. We've had this specific clinical data for nearly 4 decades.
1987. We were listening to cassettes on Sony Walkmans when researchers first proved this.
We really were.
It's crazy. They took 120 cervical cancer survivors, 80 were given HRT, and 40 were used as a control group with no hormones.
Yeah.
They tracked them, and there was absolutely no significant difference in cancer recurrence or survival between the two groups.
And the data has only expanded and solidified since then. Consider the EPIC study.
Remind me, what does that stand for?
The European Prospective Investigation into Cancer and Nutrition.
Ah, great.
It is a massive data set. They followed over 308,000 women, which included 261 with invasive cervical cancer.
Wow, that's huge.
It is. And their findings went beyond just proving safety. They actually showed a statistically significant reduction in the risk of invasive cervical cancer with HRT use.
Wait, a reduction.
A reduction, yes.
So if the science has been this clear since the 80s that cervical cancer isn't driven by hormones and that localized estrogen barely enters the bloodstream anyway, why are patients still suffering in silence?
It's a great question.
Why are they still living with a flood in their living room?
Well, because the life-saving treatments for cervical cancer are notoriously brutal on the pelvic region, and the side effects are incredibly complex to manage.
Like the radiotherapy.
Exactly. When an oncologist uses pelvic radiotherapy to eradicate cervical cancer, they are intentionally directing intense, focused radiation at the entire pelvis.
Right, to kill the cancer.
Yes, and it often cures the cancer, but it routinely causes severe radiation-induced bladder, rectal, and vaginal symptoms. We see profound vaginal toxicity, scarring, and vaginal stenosis.
Vaginal stenosis, that's where the vaginal canal literally narrows and shortens as scar tissue forms, right?
Sadly, yes.
Which makes basic biological functioning, let alone sexual intimacy, completely agonizing.
For these survivors, local estrogen isn't just a lifestyle tweak for comfort. It is vital medical care.
It's a necessity.
It truly is. It's required to aid tissue healing, increase blood flow to those heavily irradiated areas, and reduce that severe vaginal toxicity.
Wow.
To deny a cervical cancer survivor local estrogen out of a misplaced, unscientific fear of a hormone-driven recurrence, it's basically denying them a proven treatment for the direct physical damage caused by their cancer therapy.
That brings a lot of clarity to the cervical cancer side of things. It's just a tragedy of misaligned fears.
It really is.
But that peace of mind vanishes the second a patient has a tumor that actually feeds on estrogen.
Let's look at the ovarian cancer data.
This is the harder conversation, yes.
Here's where it gets really interesting. Because we were moving into much murkier, high-anxiety waters. With ovarian cancer, hormone receptors actually do change the math.
They absolutely do. The primary complexity with ovarian cancer is that up to 85% of high-grade serous or endometrioid epithelial ovarian cancers actually express estrogen receptors.
Meaning the tumor literally has a physiological lock that estrogen can act as a key for, triggering growth.
Precisely. Because the disease can be hormone sensitive in that way, systemic HRT is approached with a very high degree of caution.
That makes sense.
The guidelines are highly specific here. For FIGO stage 2 to 4 low-grade serous ovarian cancers, systemic HRT is explicitly not recommended.
Okay, so a hard no on the systemic stuff for those advanced cases. All right, in those advanced low-grade cases, the cancer is highly hormone sensitive, and there's a documented medical advantage to using estrogen-suppressing treatments to starve any remaining cells.
Okay, so let me push back on this because it feels like a massive contradiction to me.
Go ahead.
If the tumor literally has estrogen receptors and the patient had an advanced stage of a disease we know responds to hormones, how can any doctor in good conscience prescribe even a microscopic amount of vaginal estrogen?
I completely understand the hesitation.
I mean, even a temporary leak from our cracked sponge analogy seems too risky if you know the cancer feeds on that exact substance.
It's arguably the most important, valid question a patient could possibly ask their oncologist.
Right.
And to answer it, the medical community had to look at the clinical reality of what actually happens to human beings when we prescribe it, rather than just theorizing about receptors in a lab.
Okay.
This is where the Cleveland Clinic retrospective study is so illuminating. It's a first-of-its-kind analysis that tackled this specific fear head-on.
I was reading about this. They analyzed over 200 gynecological cancer survivors who were suffering from severe GSM and were prescribed vaginal estrogen.
Exactly.
And I was shocked looking at the breakdown of those patients because they didn't just play it safe with the non-hormonal cancers.
No, they didn't.
They included 62 women with cervical cancer, 127 with endometrial, and importantly, 46 women specifically with ovarian cancer.
Yes. These were women who were technically disease-free at their last checkup, but were living with the agonizing daily symptoms of GSM.
The flood in the living room.
Exactly. The researchers tracked their progress while using vaginal estrogen, specifically monitoring for the nightmare scenario recurrence.
And the recurrence rates didn't spike, even in the ovarian cancer cohort.
They found that adverse events, including cancer recurrence, were exceedingly rare across the board.
That's incredible.
The presence of topical estrogen did not trigger a systemic return of the disease.
Wow.
This brings us right back to the BGCS guidelines and that paradigm-shifting math.
The 1 pill a year math.
Exactly. Because the systemic absorption of local vaginal estrogen is so minuscule, and the healthy tissue eventually blocks further absorption entirely, it is generally not contraindicated, even when a systemic HRT patch or pill is entirely forbidden for that same patient.
But, I mean, the guidelines don't just hand out a blanket yes for everyone with ovarian cancer, right? There is a lot of caution tape around this.
So, tremendous nuance is required.
Yeah.
For a survivor with an advanced, highly hormone-sensitive ovarian cancer, a prescription isn't automatic.
Right.
The decision demands a highly individualized, collaborative risk and benefit discussion with their specific oncology team.
It's not just a quick trip to the pharmacy.
Not at all. The doctor and patient have to sit down and weigh the theoretical microscopic risk of that tiny initial systemic absorption against the absolute certainty of the patient's current daily physical suffering.
It's weighing a phantom risk against a very real present-day flood in your living room.
That's exactly it.
So, having established that localized estrogen is definitively safe for cervical cancer, and generally safe with highly individualized caution for ovarian cancer, how do we actually execute this?
The application part.
Yeah, what is the practical application? Because the guidelines make it clear you don't just jump straight to the strongest hormone available.
Yeah, you don't. The latest NICE-E guidelines and the British Menopause Society dictate a very clear stepped approach. It's a treatment ladder that prioritizes caution while ensuring relief.
Walk us through the rungs of that ladder, because step one doesn't even involve hormones at all, does it?
No, it doesn't. Step one is always to aggressively explore non-hormonal options first.
Like what?
This means starting with high-quality, specialized vaginal moisturizers used regularly throughout the week, combined with medical-grade lubricants used specifically during intimacy.
Okay.
For some women, this non-hormonal hydration is actually enough to manage the tissue dryness, restore comfort, and prevent micro-tears.
But we know that for a lot of survivors with severe radiation damage or surgical menopause, moisturizers are kind of like bringing a water pistol to a house fire.
Unfortunately, yes.
What happens when the symptoms are refractory, meaning they just aggressively continue despite all those non-hormonal treatments?
That's when the medical team moves to step two. Step two is introducing ultra-low dose topical estrogen. We are talking about estriol creams, or estradiol 10 microgram vaginal tablets.
10 micrograms. For context, that is an incredibly tiny, highly localized dose.
It really is. And if we connect this to the bigger picture, it's crucial for patients to understand that they don't have to choose between rung 1 and rung 2 of the ladder.
Oh, really?
Yeah, it isn't an either-or scenario. They can and often should use vaginal estrogen to heal the tissue in combination with non-hormonal moisturizers to maintain daily hydration.
Okay, so it's like a tiered security system for your house. You try the basic deadbolts first, the non-hormonal moisturizers. And if the intruder, in this case, severe pain and tissue damage, keeps getting in, you bring out the heavy, ultra-low dose estrogen alarms.
That's a great way to look at it.
But this system gets incredibly messy if the house is already wired to a completely different conflicting security company. For instance, if a patient is on an aromatase inhibitor...
The drug interactions are a critical hurdle, yes.
Tell me about that.
Well, the NHS and non-size guidelines are highly specific about a class of adjuvant cancer drugs called aromatase inhibitors.
Since those drugs are specifically designed to hunt down and eliminate every last drop of peripheral estrogen in the body, driving levels down to absolute zero, putting an estrogen cream anywhere near that system feels like intentionally tripping the alarm.
It does.
Even that temporary tiny spike from our cracked sponge phase would be a massive red flag.
The guidelines agree with you. If a patient is on an aromatase inhibitor, topical estrogen should generally be avoided.
Because of the spike.
Yes. The medical concern is that even the microscopic absorption we talked about could theoretically be enough to temporarily negate the efficacy of the aromatase inhibitor, giving the cancer a tiny window of opportunity.
So a patient in that specific scenario is just stuck. The floodwaters just keep rising.
Not necessarily.
Oh.
This is where medical ingenuity and collaboration shine. In those complex cases, oncologists might consider switching the patient from an aromatase inhibitor to a different adjuvant drug called tamoxifen.
I love the mechanics of this workaround because tamoxifen still fights the cancer, but it doesn't try to eradicate the estrogen itself.
Exactly.
It acts as a blocker at the receptor site. It essentially jams a broken key into the lock on the cancer cell so the real estrogen key can't get in.
That's a perfect description. Because tamoxifen actively blocks the receptors, it makes using local vaginal estrogen significantly safer.
Oh, that makes sense.
Yeah, even if a tiny amount of that topical estrogen temporarily absorbs systemically through the healing tissue, the cancer's receptors are already blocked and protected.
It's an incredibly elegant medical loophole.
It really is.
But it really highlights how vital it is for the patient's gynecologist and their primary oncologist to actually pick up the phone and talk to each other.
Oh, absolutely. Siloed medicine fails cancer survivors. No changes to cancer medication or the introduction of hormones should ever be initiated without the primary oncology team actively leading the discussion.
So what does this all mean? We've covered a massive amount of biology, clinical studies, and guidelines today.
We have.
But if you are listening to this, the core takeaway is empowerment. A cancer diagnosis does not mean you are required to accept a life of silent suffering from severe menopausal symptoms.
Absolutely not.
The science, firmly backed by the 2024 BGCS and BMS guidelines, strongly supports the localized, safe use of topical estrogen for the vast majority of cervical and ovarian cancer survivors.
Yes, the systemic absorption is minimal, the local healing is profound, and even with hormone-sensitive cancers or complex drug regimens, there are clever pathways and protocols to find real relief. And, there is one final vital consequence of this entire debate that we haven't touched on yet.
What's that?
It comes straight from the NHS Somerset ICB data.
Okay.
We've spent this deep dive talking about the fear of cancer recurrence. But consider this tragic irony. Many gynecological cancer survivors completely stop attending their vital follow-up screening appointments.
You mean their smear tests and routine vulval examinations?
Yes.
Oh. Because untreated genitourinary syndrome of menopause makes the exams physically agonizing.
Exactly. The tissue is so fragile and atrophied that a simple speculum exam becomes unbearable, so they skip the appointment entirely.
Oh my God.
It raises an important question for the listener. By avoiding localized estrogen out of a fear of cancer recurrence, could a survivor actually be increasing their risk of a missed recurrence simply because the physical pain of untreated menopause drove them away from their life-saving surveillance exams?
You survive the fire, you fear the water damage, but by avoiding the fix, you stop checking the smoke detectors.
It is a devastating cycle.
It really is. Listen, if you or someone you love is putting off these vital exams because of pain or living with a compromised quality of life, take this information directly to your medical team.
Yes, please do.
Take these 2024 guidelines to your oncologist. Start an empowered conversation about your daily reality. You fought incredibly hard to survive the fire. You deserve to actually live comfortably in the house you saved.